All right, welcome everyone to another deep dive. Today we're going to be looking at acute cholecystitis and cholangitis. And as always, we're going to be focusing this deep dive specifically for you, our audience of medical microbiologists.
It's always good to be here.
Now, guide us through this journey today. We're going to be focusing on the AWARE guidance on antibiotic use from the World Health Organization. And specifically, we're going to be looking at the chapter on intra-abdominal infections.
That's a great chapter. It covers a lot of ground, and it's really helpful for making those tough antibiotic decisions.
Now, for this deep dive, we're going to follow a specific structure to make sure we cover all the bases. We're going to start with, of course, the definition of the conditions. We're going to talk about the clinical presentation. Then we'll move on to the essential laboratory tests. And of course, that'll include both the microbiology tests you all know and love,
Can't forget those.
as well as some other important lab tests that you might want to consider. After that, we'll talk about imaging. Then we'll move on to the all-important topic of treatment.
That's where the rubber meets the road.
Exactly. And within treatment, we'll specifically delve into antibiotic treatment, making sure to cover those tricky dosages and duration questions that often come up.
Dosages can be a real headache sometimes.
Right. Then we'll take a step back and look at the pathophysiology of these conditions, understanding those underlying mechanisms that drive these infections. After that, we'll broaden our perspective and delve into the epidemiology of both acute cholecystitis and cholangitis, looking at those global trends and risk factors.
It's always fascinating to see how these conditions play out on a larger scale.
It is. And finally, we'll wrap up by discussing those most likely pathogens, making sure you're armed with the knowledge to identify and target those microbial culprits. And just to keep things interesting, we've got a few exam-style questions sprinkled throughout the deep dive to test your knowledge and make sure you're staying sharp.
I love a good challenge.
All right, so let's jump right in. Starting with the definition, could you give us a clear and concise definition of both acute cholecystitis and cholangitis, highlighting those key features that distinguish these conditions?
Absolutely. So acute cholecystitis, simply put, is an inflammation of the gallbladder. And it's most commonly caused by a gallstone that gets lodged in the cystic duct. Now, the cystic duct, that's the little tube that connects the gallbladder to the common bile duct. And when that duct gets blocked, it causes bile to back up, leading to inflammation and, you guessed it, infection. Now, cholangitis, on the other hand, is an inflammation of the bile duct system itself. And this can be caused by a few different things. The most common is, again, a gallstone, but it can also be caused by tumors, strictures, or even certain parasitic infections. And the key thing to remember here is that cholangitis is generally considered a more serious condition than acute cholecystitis because it involves a blockage of the common bile duct, and that can lead to a buildup of pressure and bile within the liver. And we all know that's not a good thing.
It's not. That's a fantastic overview. Now, when we're talking about these conditions, it's important to distinguish between uncomplicated and complicated cases. Could you elaborate on that a bit?
Sure. So in uncomplicated cases, the inflammation is confined to the gallbladder or bile ducts. But in complicated cases, the infection can spread beyond those structures, leading to peritonitis, which is inflammation of the lining of the abdominal cavity, or even to abscess formation, which is a collection of pus somewhere in the abdomen.
And those abscesses, those can be tricky to manage, right?
Yeah.
They often require drainage and prolonged courses of antibiotics.
They can be real headaches. And peritonitis, that's a whole other ballgame. It's a serious condition that can quickly become life-threatening if it's not treated promptly.
Absolutely. So we need to be vigilant for those signs of complications, especially in those patients who are more vulnerable to severe infections.
Agreed. Now, when we're thinking about complications, peritoneal cavity involvement is a big one. That's when the infection spills out beyond the gallbladder or bile ducts and starts to irritate the peritoneum, which is that membrane that lines the abdominal cavity. And that can lead to a whole cascade of problems.
Right. It's like a domino effect, with the infection triggering widespread inflammation and potentially leading to sepsis.
Exactly. And those abscesses, they can pop up anywhere in the abdomen, making it tricky to pinpoint the source of infection.
Okay, so we've got a good grasp of those key definitions and the distinction between uncomplicated and complicated cases. Now let's move on to the clinical presentation. What are some of those classic signs and symptoms that should raise our suspicion of acute cholecystitis or cholangitis?
Well, the hallmark symptom of acute cholecystitis is that classic right upper quadrant pain. It's often described as a sharp, cramping pain that can radiate to the right shoulder or back. And it's typically triggered by eating, especially fatty foods.
The fatty foods, they really put the gallbladder to work, don't they?
They do. They stimulate the gallbladder to contract and release bile, and when there's a blockage, that contraction can cause intense pain.
Right. So that pain after a fatty meal is a big red flag.
Absolutely. Now, in addition to that right upper quadrant pain, patients with acute cholecystitis often present with fever, nausea, and vomiting. And sometimes they might even have a palpable mass in the right upper quadrant, which is the inflamed gallbladder itself.
So it's a constellation of symptoms that point us in the direction of the gallbladder.
Exactly. Now, cholangitis, on the other hand, it often presents with a similar set of symptoms, but there are a few key distinctions. First, the pain might be more persistent and less colicky than an acute cholecystitis. And second, patients with cholangitis often develop jaundice.
Jaundice, that's the yellowing of the skin and eyes caused by a buildup of bilirubin in the blood.
And it's a classic sign of biliary obstruction, right?
Exactly. That bilirubin, it's a breakdown product of red blood cells, and is normally excreted in the bile. But when the bile duct is blocked, that bilirubin backs up, spills into the bloodstream, and stains the tissues. Right, so jaundice in a patient with abdominal pain and fever is a strong indicator of cholangitis.
It is. Now, in addition to jaundice, patients with cholangitis often have a more pronounced fever and a faster heart rate than those with acute cholecystitis. And in severe cases, they might even develop confusion or altered mental status, which is a sign that the infection is really taking hold.
So it's a more systemic illness, with the infection potentially affecting other organ systems.
Precisely. Now remember, these are just the classic presentations. Not every patient will textbook. Sometimes those symptoms can be more subtle, especially in the elderly or in those with underlying health conditions.
Right. We need to be mindful of those atypical presentations and keep a high index of suspicion, especially in those vulnerable populations.
Now let's talk about those red flags, because recognizing those signs of a complicated infection can be absolutely crucial.
It can be the difference between a timely intervention and a delayed diagnosis that leads to serious complications.
Exactly. So if a patient presents with severe abdominal pain, especially if it's accompanied by rebound tenderness, which is pain that worsens when you release pressure on the abdomen.
Right, it's like pressing on a bruise. It only hurts when you let go.
Exactly. Or if they have muscular guarding, which is involuntary tensing of the abdominal muscles, those are signs that the peritoneum is irritated. And that should raise a huge red flag.
It's the body's way of saying, hey, someone's seriously wrong in here.
Right. Those are signs of peritonitis. And we need to act quickly to identify the source of infection and get those appropriate treatments underway.
Absolutely. Now, shifting gears to laboratory tests. What tests can help us confirm the diagnosis and guide our treatment decisions?
Well, the first thing we always want to do is get a complete blood count, or CBC, and that'll give us a good overall picture of the patient's health and help us assess the severity of the infection.
Right. We're looking for that elevated white blood cell count, a sign that the body is mounting an immune response to fight off that infection.
Exactly. Now, in addition to the CBC, we also want to get some liver function tests, or LFTs. And these tests measure the levels of certain enzymes and proteins in the blood that are produced by the liver. And because the liver and biliary system are so intimately connected, any disruption in the biliary system can affect liver function.
So those LFTs can give us a clue as to whether the liver is being affected by the infection or obstruction.
They can. Now, specifically, we're looking at the levels of AST, ALT, bilirubin, and alkaline phosphatase. Elevated levels of these markers can indicate liver damage or bile duct obstruction.
So those LFTs are an important piece of the puzzle.
They are. Now, another valuable test is the C-reactive protein, or CRP. And CRP is a marker of inflammation, and it's often elevated in acute cholecystitis and cholangitis.
So it's another indicator of that inflammatory process that's driving these conditions.
Exactly. Now, one test that's becoming increasingly popular is procalcitonin. And procalcitonin is a protein that's produced by the body in response to bacterial infections.
So it's a more specific marker of bacterial infection than CRP.
It is, and it's particularly useful in distinguishing bacterial infections from other inflammatory conditions.
Right, because inflammation can be triggered by a variety of things, not just bacteria.
Exactly. Now, in the context of acute cholecystitis and cholangitis, elevated procalcitonin levels can help us confirm a bacterial cause for the infection and guide our antibiotic choices.
So it's like an extra layer of information to help us make those critical treatment decisions.
It is. Now, in addition to those blood tests, we also want to consider some microbiology tests. And these tests, of course, are the bread and butter of medical microbiology. They help us identify the specific bacteria that are causing the infection.
And that identification is crucial for tailoring our antibiotic therapy.
It is. Now, the most important microbiology test is the blood culture. And blood cultures are taken to see if bacteria are present in the bloodstream. And this is especially important in cases of cholangitis, where the risk of bacteremia or bacteria in the blood is higher.
Right, because that biliary obstruction can create a pathway for those bacteria to escape into the bloodstream and spread throughout the body.
Exactly. Now, ideally, blood cultures should be taken before starting antibiotics, because once antibiotics are on board, it can be harder to grow those bacteria in the lab.
So timing is key with those blood cultures.
It is. Now, in addition to blood cultures, we might also want to consider culturing abdominal fluid or bile if those are obtained during drainage procedures.
Right. If there's an abscess that needs to be drained or if a biliary drainage procedure is performed, we can send those specimens to the lab to identify those culprit bacteria.
Exactly. And those culture results can really help us refine our antibiotic choices and make sure we're targeting the right bacteria.
It's all about precision medicine, tailoring our therapy to the specific pathogens that are causing the infection.
Precisely. Now let's shift gears and talk about imaging. What imaging modalities can help us visualize the biliary system and confirm the diagnosis?
Imaging is essential in these cases, isn't it? It allows us to see what's happening inside the body and confirm our clinical suspicions.
It is. The go-to imaging test for both acute cholecystitis and cholangitis is the abdominal ultrasound. And ultrasound uses sound waves to create images of the organs and structures inside the abdomen. It's a non-invasive, painless, and relatively quick procedure, and it's highly effective at visualizing the gallbladder and bile ducts.
So we can see those telltale signs of inflammation like a thickened gallbladder wall or dilated bile ducts.
Exactly. Now, in cases where the ultrasound findings are inconclusive, or if we suspect complications like abscess formation or perforation, we might need to order a CT scan.
The CT scans, those use X-rays to create cross-sectional images of the body, providing a more detailed view of the anatomy.
Right, and CT scans can be especially helpful in visualizing those tricky areas around the gallbladder and bile ducts. They can help us detect those hidden abscesses or assess the extent of inflammation and damage.
So CT scans are like our high-resolution lens, zooming in on those areas where ultrasound might fall short.
Yeah, exactly. Now, in certain cases, we might also consider other imaging modalities like magnetic resonance, cholangiopancreatography, or MRCP. And MRCP is a specialized MRI technique that focuses on the biliary and pancreatic ducts, providing detailed images of those structures.
So it's like a VIP pass to the biliary system, allowing us to see those intricate details that other imaging modalities might miss.
Exactly. Now, the choice of imaging modality will depend on the specific clinical scenario, the availability of those different techniques, and the expertise of the radiologist interpreting those images.
It's a team effort, with the clinician and radiologist working together to get the best possible view of the biliary system.
Precisely. Okay, so we've covered the definition, the clinical presentation, those essential laboratory tests, and the imaging modalities that can help us confirm the diagnosis. Now let's dive into the all-important topic of treatment.
And treatment for these conditions often involves a multidisciplinary approach, right? We've got surgeons, gastroenterologists, radiologists, and of course medical microbiologists all playing a crucial role.
Absolutely. It's a team effort, with each specialty bringing its expertise to the table to ensure the best possible outcome for the patient. Now, the cornerstone of treatment for both acute cholecystitis and cholangitis is source control. And what that means is eliminating the underlying cause of the infection, which in most cases is that blockage in the biliary system.
So it's about removing that roadblock, allowing that bile to flow freely again.
Exactly. Now, for acute cholecystitis, the definitive treatment is cholecystectomy, which is the surgical removal of the gallbladder.
So it's a farewell to that troublesome gallbladder.
It is. Now, cholecystectomy can be performed either laparoscopically, which means using small incisions and a camera to guide the surgery, or it can be done open, which involves a larger incision in the abdomen.
Laparoscopic surgery is generally preferred, right? It's less invasive, has a shorter recovery time, and fewer complications.
It is. Now, for acute cholangitis, source control involves biliary drainage, and that means relieving the blockage in the common bile duct to allow that bile to drain properly.
And how is that drainage typically accomplished?
Well, there are a few different techniques. One common approach is endoscopic retrograde cholangiopancreatography, or ERCP. And ERCP is a procedure where a flexible endoscope with a camera and instruments attached is inserted through the mouth, down the esophagus, and into the duodenum. And then, using X-ray guidance, a small catheter is inserted into the common bile duct to remove the blockage.
So it's like a plumbing job, but instead of pipes, we're dealing with bile ducts.
Exactly. Now, other techniques for biliary drainage include percutaneous transhepatic cholangiography, or PTC, and that involves inserting a needle through the skin and into the liver to access the bile ducts, or surgery, where a surgeon directly accesses the common bile duct to remove the blockage.
So we've got a range of options for achieving source control in acute cholangitis, and the choice of technique will depend on the specific clinical scenario and the expertise of the interventional team.
Absolutely. Now, while source control is the primary focus of treatment, antibiotics also play a crucial role in managing these infections. They help control bacterial growth, prevent the spread of infection, and reduce the risk of complications.
And that's where our trusty guide, the AWARE guidance on antibiotic use, comes in.
It does. The AWARE guidance provides a framework for choosing the right antibiotics, considering the severity of the infection, local resistance patterns, and individual patient factors.
Right. We're not just throwing antibiotics at the problem. We're using them strategically and thoughtfully.
Exactly. Now let's delve into those AWARE recommendations, starting with mild, uncomplicated cases of acute cholecystitis. What are our go-to choices in those scenarios?
Those mild cases, they're the ones that often make us pause and think, do we even need antibiotics, or can we just focus on source control?
Right, it's a delicate balance. Now, the AWARE guidance suggests that in mild, uncomplicated cases of acute cholecystitis that are treated with cholecystectomy, antibiotics can be stopped once the surgery is complete.
So no need to prolong treatment unnecessarily, especially if the source of infection is gone.
Exactly. But even if we're planning to stop antibiotics after surgery, it's still recommended to start with empiric therapy, meaning we choose antibiotics based on the most likely pathogens without waiting for culture results.
And the rationale for that?
Well, it's all about covering those bases and preventing those potential complications that can arise from uncontrolled bacterial growth. We want to hit those bacteria hard and fast, especially in the perioperative period, to minimize the risk of infection spreading.
So it's a proactive approach, hitting those bacteria hard before they have a chance to establish a foothold. Now, what specific antibiotics does the AWARE guidance recommend for those mild, uncomplicated cases?
Well, for adults, the first-line option is amoxicillin clavulanate. It's a good choice because it covers those common gram-negative and anaerobic bacteria that we often encounter in these infections.
And what about dosage? Those details can be tricky sometimes.
You're right. Dosage is important. For adults, the typical dose of amoxicillin clavulanate is 1 gram of amoxicillin and 200 milligrams of clavulanate given every 8 hours intravenously.
And if the patient can tolerate oral medications, can we switch to the oral route?
We can. If the patient's clinical condition allows for oral therapy, we can switch to 875 milligrams of amoxicillin and 125 milligrams of clavulanate given every 8 hours orally.
So we have some flexibility depending on the patient's situation. Now, what if amoxicillin clavulanate isn't an option, perhaps due to allergies or concerns about resistance?
In those cases, the AWARE guidance recommends a combination of a third-generation cephalosporin, like ceftriaxone or cefotaxime, along with metronidazole. This combination provides broad coverage against those gram-negative and anaerobic bacteria.
And those cephalosporins, they're known for their good penetration into tissues, making them a good choice for these intra-abdominal infections.
They are. Now, for ceftriaxone, we typically give 2 grams once a day intravenously. And for cefotaxime, it's 2 grams every 8 hours, also intravenously. And regardless of which cephalosporin we choose, we're combining it with 500 milligrams of metronidazole every 8 hours, which can be given either intravenously or orally.
So we've got our first-line options covered for those mild, uncomplicated cases. But what about those situations where we need to bring out the big guns, those severe cases where the infection is really taking hold? What does the AWARE guidance recommend for those?
When things get serious, we need to step up our antibiotic game. For severe cases of acute cholecystitis in adults, we can stick with the cephalosporin-metronidazole combination, using the same dosages as for mild cases, or we can opt for piperacillin-tazobactam.
Piperacillin-tazobactam, that's a broad-spectrum powerhouse that covers a wide range of potential pathogens, including those pesky Pseudomonas species that can sometimes complicate these infections.
It is. And the usual dose for adults is 4 grams of piperacillin and 500 milligrams of tazobactam given every 6 hours intravenously.
Now, we can't forget about those tricky ESBL-producing bacteria that are becoming increasingly prevalent. What does the AWARE guidance say about tackling those?
You're right, those ESBLs are a major concern. If there's a high risk of infection with ESBL-producing enterobacterales, particularly in severe cases, the guidance recommends considering meropenem. It's our carbapenem friend, reserved for those really tough situations where we need to hit those resistant organisms hard.
Meropenem. It's our weapon of choice when those ESBLs are lurking. And how is it typically dosed in these cases?
The usual dose for adults is 1 gram every 8 hours intravenously.
Now, before we move on to duration of treatment, I want to touch on an important point. The AWARE guidance is a fantastic resource, but it's not just about blindly following the recommendations. We need to use our clinical judgment and consider individual patient factors, right?
Absolutely. The guidelines provide a framework, but we need to apply them thoughtfully. For example, if a patient has underlying liver or kidney issues, we might need to adjust dosages or choose alternative antibiotics. And we always need to be mindful of de-escalating to narrow-spectrum antibiotics based on culture results or clinical improvement.
De-escalation. That's a key principle of antimicrobial stewardship, right? We want to use the most targeted therapy possible to minimize the risk of developing resistance.
It is. We start with broad-spectrum antibiotics when we're unsure of the culprit, but as soon as we get those culture results, we narrow down our antibiotic choice to target that specific pathogen.
It's like adjusting our aim, making sure we're hitting the bullseye with our antibiotic therapy.
Exactly. And by practicing good antimicrobial stewardship, we can preserve the effectiveness of these life-saving drugs for future generations.
Absolutely. Now, I imagine there are times when symptoms persist despite treatment. What should we do then? Do we just throw more antibiotics at the problem?
Not necessarily. If a patient isn't responding as expected, it's crucial to take a step back and reevaluate. We need to consider whether there are any complications that we might have missed initially. Maybe an abscess has formed or the infection has spread beyond the biliary system.
So it's like being a detective looking for those subtle clues that might explain why the treatment isn't working.
Exactly. We might need to repeat imaging studies or consider additional laboratory tests to get a clearer picture of what's going on. And sometimes we might need to consider whether there's an alternative source of infection, perhaps outside the abdomen, contributing to the persistent symptoms.
So it's a reminder to think broadly and consider all possibilities.
Right. We can't get tunnel vision. We need to keep an open mind and be willing to adjust our approach based on the evolving clinical picture.
Okay, so we've covered a lot of ground regarding antibiotic choices for adults. But before we move on to duration of treatment, let's take a quick detour and talk about our younger patients. Children aren't just miniature adults. They have unique physiological differences that impact how they metabolize and respond to antibiotics.
You're absolutely right. Children's bodies are still developing, and their immune systems are not as robust as those of adults. So we need to choose our antibiotics carefully and adjust those dosages precisely to ensure that we're treating them safely and effectively.
And the AWARE guidance provides specific recommendations for pediatric cases, recognizing those unique needs.
It does. Now, for mild cases of acute cholecystitis in children, the guidance suggests starting with a combination of ampicillin and gentamicin, both given intravenously. And those intravenous antibiotics, they ensure that we achieve those high drug levels that are often needed to fight off those infections.
Right. And because children can sometimes be picky eaters, or their stomachs might be upset from the infection, intravenous administration ensures that those antibiotics are getting into the bloodstream where they need to be.
Exactly. Now, in addition to ampicillin and gentamicin, we're also giving metronidazole, which can be given either intravenously or orally. That metronidazole, it targets those anaerobic bacteria that can often complicate these infections.
So it's our triple threat, covering those gram-positive bacteria with ampicillin, those gram-negative bacteria with gentamicin, and those anaerobic bacteria with metronidazole.
Precisely. Now, if the child is able to tolerate oral medications, we can consider switching to amoxicillin clavulanate, cefotaxime, or ceftriaxone, all combined with metronidazole. These oral options provide good coverage against the typical pathogens we encounter in these pediatric cases.
So we have some flexibility depending on the child's clinical condition and their ability to tolerate oral medications. Now, just like in adults, we have second-line options for children if those initial choices aren't suitable. What are those?
If the first-line options aren't appropriate, we can turn to a combination of ciprofloxacin and metronidazole, both given orally. Or if we need to stick with the intravenous route, we can use ampicillin and gentamicin, both along with metronidazole.
So the choices mirror the adult recommendations quite nicely, but with those carefully adjusted dosages for these young patients. Now, I know those dosages can be tricky to calculate, especially for the intravenous options. Can you walk us through those calculations?
Absolutely. For ampicillin, the intravenous dosage is 50 milligrams per kilogram of body weight, given every 12 hours during the first week of life and every 8 hours thereafter. Gentamicin is given intravenously at a dose of 5 milligrams per kilogram once daily for neonates and 7.5 milligrams per kilogram once daily for older children. And metronidazole, whether given intravenously or orally, is dosed at 7.5 milligrams per kilogram every 12 hours for neonates, with a loading dose of 15 milligrams per kilogram for intravenous administration. For older children, it's 7.5 milligrams per kilogram every 8 hours.
So those weight-based calculations, they ensure that we're giving the right amount of antibiotic for each child's individual size.
Exactly. And those loading doses, they help us achieve therapeutic drug levels quickly, especially in those severe cases where time is of the essence.
Now, what about severe cases in children? Do those warrant a different approach?
When things take a turn for the worse in children, the AWARE guidance emphasizes a combination of ampicillin, gentamicin, and metronidazole, all given intravenously, to really hit those infections hard. And as we mentioned before, if there's a high risk of infection with those ESBL-producing Enterobacterales, we might need to consider either piperacillin tazobactam or, in select cases, meropenem.
So we're escalating our antibiotic therapy based on the severity of the infection and the potential for resistant organisms.
We are. And just like in adults, those dosages are carefully adjusted based on the child's weight.
Okay, so we've covered a lot of ground regarding antibiotic choices for both adults and children. Now let's talk about duration of treatment. How long do we keep those antibiotics flowing? Because I know that's a question that often sparks debate.
It does. There's no one-size-fits-all answer. But the AWARE guidance provides some helpful guidelines, and as always, it emphasizes individualizing treatment based on the clinical scenario. Now, for acute cholecystitis, if the patient underwent cholecystectomy and is recovering well, we can typically stop antibiotics once the gallbladder is removed.
So no need to prolong treatment unnecessarily.
Exactly. But if the presentation was severe or there were complications like abscesses or peritonitis, we typically continue antibiotics for 5 days after surgery, just to make sure those antibiotics have enough time to mop up any lingering bacteria.
And that 5-day rule, does that apply to acute cholangitis as well?
It does. For acute cholangitis, even in mild cases, antibiotics are continued until biliary drainage procedures are performed, and for a total of 5 days after successful source control. That 5-day rule, it emphasizes the importance of achieving source control, which means removing that blockage and allowing those antibiotics to do their job.
All right, so we've got our duration guidelines, remembering to individualize treatment based on the specific clinical scenario. Now, before we move on to pathophysiology, I want to touch on an important point that you mentioned earlier, de-escalation of antibiotics. Could you elaborate on that a bit more? Because I think it's a concept that sometimes gets lost in the hustle and bustle of clinical practice.
Absolutely. De-escalation of antibiotics, it's all about refining our antibiotic choices based on new information. We often start with broad-spectrum antibiotics when we're unsure of the specific bacteria causing the infection. But once those culture results come back, we can often switch to a narrower spectrum antibiotic that specifically targets that identified pathogen.
So it's like narrowing our focus, using a more precise weapon to attack the enemy.
Exactly. And there are several benefits to de-escalation. First, it helps to reduce the risk of developing antibiotic resistance. When we use broad-spectrum antibiotics, we're essentially carpet bombing the microbial world, killing off both the good and bad bacteria, and that creates an environment where those resistant strains can thrive.
Right. It's like clearing the playing field for those superbugs to take over.
Exactly. But when we use narrow-spectrum antibiotics, we're targeting a specific pathogen, minimizing the collateral damage to the rest of the microbial community.
So we're preserving those good bacteria that help to keep those harmful ones in check.
Right. Now, another benefit of de-escalation is that it can reduce the risk of side effects. Broad-spectrum antibiotics, they can disrupt the normal balance of bacteria in the gut, leading to diarrhea, nausea, and other gastrointestinal problems.
And in some cases, those broad-spectrum antibiotics can even cause more serious side effects, like kidney damage or allergic reactions.
They can. But when we use narrow-spectrum antibiotics, we're minimizing those risks because we're targeting a specific pathogen, and we're often able to use a lower dose of the antibiotic.
So it's a win-win situation.
Yeah.
We're reducing the risk of resistance and side effects while still effectively treating the infection.
Exactly. Now, de-escalation isn't always possible, of course. Sometimes we need to stay with those broad-spectrum antibiotics if the infection is severe or if there are concerns about resistant organisms. But it's always something we should be thinking about, especially once those culture results come back.
Right. It's about being good stewards of those precious antibiotics and using them in the most responsible and effective way possible.
Absolutely.
Okay, so we've covered a lot of ground regarding antibiotic choices and the importance of de-escalation. Now let's shift gears and delve into the fascinating world of pathophysiology, those mechanisms that drive these infections.
I love pathophysiology. It's like taking a peek under the hood and understanding the inner workings of these conditions.
It is. It helps us connect those dots and see how the various pieces of the puzzle fit together. Let's start with acute cholecystitis. What sets the stage for this inflammatory process?
Well, in the vast majority of cases, the culprit is a gallstone obstructing the cystic duct. And as we discussed earlier, that blockage creates a bottleneck in the biliary system, causing bile to back up and the gallbladder to swell.
And that pressure buildup must be incredibly painful.
It certainly contributes to the intense pain that patients experience, but the consequences go beyond discomfort. The gallbladder wall becomes inflamed and irritated, creating a prime environment for bacteria to flourish.
So that gallstone sets off a chain reaction. Obstruction, pressure, inflammation, and ultimately infection.
Exactly. And the bacteria that typically seize this opportunity are those that normally reside in the gut, like E. coli and Klebsiella. They find their way into the gallbladder either through the bloodstream or by ascending from the small intestine.
So the gut microbiome, which is usually our friend, turns into a foe in these cases.
Precisely. Now, while gallstones are the most common trigger for acute cholecystitis, there's a less common form called a calculous cholecystitis. And in this form, there are no gallstones involved.
So inflammation without the classic gallstone blockage, what causes that?
Well, the exact mechanisms aren't fully understood, but a calculous cholecystitis is often associated with severe illness, major trauma, or conditions that compromise blood flow to the gallbladder. Think of situations like sepsis, burns, or prolonged fasting.
So it's like the gallbladder is being stressed or starved, making it more vulnerable to inflammation.
That's a great way to think about it. And while it's less common, we can't forget about those parasitic infections that can also contribute to cholecystitis, particularly in certain regions of the world.
You're talking about those roundworms that can migrate into the biliary system, causing obstruction and inflammation.
Exactly. Those parasitic infections, they add another layer of complexity to the pathophysiology of acute cholecystitis. Now, what about acute cholangitis? How does the story unfold in that condition?
Let's unravel that mystery. It seems like gallstones are a common theme in these biliary infections.
You're right. Gallstones can certainly play a role in acute cholangitis as well. They can lodge in the common bile duct, causing obstruction and setting the stage for infection. But in cholangitis, we also need to be mindful of other culprits.
Like those malignant obstructions we discussed earlier.
Exactly. Tumors, either in the bile ducts themselves or in nearby organs, can compress or invade the duct, leading to obstruction and setting the stage for cholangitis.
So those malignant obstructions are a major concern in cholangitis, adding another layer of complexity to the diagnostic puzzle.
They are, and just like in cholecystitis, parasitic infections can also contribute to cholangitis. The liver fluke, Fasciola hepatica, which likes to hang out in the bile ducts, can cause both inflammation and obstruction, creating a perfect storm for bacterial infection.
So we've got a mix of gallstones, tumors, and even parasites contributing to cholangitis. And just like in cholecystitis, that obstruction triggers a cascade of events: pressure buildup, inflammation, and ultimately bacterial infection.
Precisely.
Yeah.
And the bacteria that often seize this opportunity are those familiar faces from the gut. E. coli, Klebsiella, Enterobacter, among others. They thrive in that bile-rich environment, causing inflammation and wreaking havoc in the biliary system.
And those anaerobic bacteria are probably right there in the mix, especially if abscesses form.
You're absolutely right. Anaerobes, particularly Bacteroid species, love those oxygen-deprived environments within abscesses. They can complicate the picture and make treatment more challenging.
So it's a complex interplay of factors that contribute to these biliary infections. And understanding those underlying mechanisms is crucial for making those critical diagnostic and treatment decisions.
Absolutely. Now, before we shift gears to epidemiology, I want to touch on one more crucial point. Why are these conditions so dangerous? What makes them more than just a painful nuisance?
That's a great question. I think we tend to focus on the symptoms, but the potential complications are what make these conditions so serious.
Exactly. The real danger lies in the possibility of those infections spreading beyond the biliary system, causing widespread inflammation and potentially life-threatening complications.
Like peritonitis, that terrifying inflammation of the abdominal lining that can quickly spiral into sepsis.
Precisely. And those abscesses we discussed earlier, they can also cause significant problems, often requiring drainage procedures and prolonged antibiotic treatment.
So we're not just dealing with a localized infection. We're trying to prevent those cascading events that can put a patient's life at risk.
Absolutely. Prompt diagnosis, surgical intervention to eliminate the source of infection, and appropriate antibiotic therapy are all essential components of managing these conditions effectively and preventing those devastating complications.
Okay, so we've laid a solid foundation for understanding the pathophysiology of acute cholecystitis and cholangitis. Now let's broaden our perspective and delve into the fascinating world of epidemiology. I always find it intriguing to see how these conditions play out on a larger scale, affecting populations and revealing patterns of disease.
It's like zooming out and seeing the bigger picture, understanding those global and local factors that influence the spread and impact of these conditions. Let's start with acute cholecystitis. It's actually a fairly common condition worldwide, although its incidence has been declining in recent years.
That's interesting. Why the downward trend? Is it a case of better hygiene or lifestyle changes?
It's largely attributed to the increasing use of cholecystectomy, the surgical removal of the gallbladder. As a preventative measure for people who experience recurrent biliary colic, in other words, if you have frequent episodes of pain due to gallstones, many surgeons will recommend removing the gallbladder to prevent future attacks, including acute cholecystitis.
So it's a proactive approach, addressing the root cause to prevent those recurring problems and potentially more serious complications.
Exactly. Now, while the overall incidence might be declining, certain groups are still more vulnerable to developing acute cholecystitis. Age is a significant factor. The risk increases as we get older. And those familiar risk factors we discussed earlier, obesity, diabetes, high cholesterol, they all play a role as well.
Those factors, they all contribute to the formation of gallstones, those tiny troublemakers that can obstruct the cystic duct and trigger that inflammatory cascade.
You're absolutely right. So individuals with these conditions are more likely to experience acute cholecystitis. It's a complex interplay of age, lifestyle factors, and underlying medical conditions that influences a person's susceptibility to this condition.
It's fascinating how those pieces fit together, painting a picture of who's most at risk. Now, what about mortality rates? How deadly is acute cholecystitis?
Fortunately, in most cases, acute cholecystitis is successfully treated with surgery and antibiotics. The short-term 30-day mortality rate is relatively low, around 1% for mild cases.
That's reassuring. But what about those more severe cases, especially those complicated by peritonitis or sepsis?
In those severe cases, the mortality rate unfortunately increases, reaching about 5%.
That highlights the importance of prompt diagnosis and treatment, preventing those complications, and ensuring the best possible outcomes for our patients. Now let's turn our attention to acute cholangitis. How does its epidemiology compare to acute cholecystitis?
Acute cholangitis is a less common condition than acute cholecystitis, but it carries a much higher mortality rate if left untreated. It's a condition that demands our attention and a swift, well-coordinated response.
That's concerning. Why is it so dangerous? Is it related to the location of the infection or the types of bacteria involved?
The primary reason for its increased danger is that the obstruction in cholangitis often involves the common bile duct, the main channel that drains bile from both the liver and the gallbladder. This blockage can lead to a buildup of bile and pressure within the entire biliary system, putting significant strain on the liver.
So it's not just an infection, it's a potential threat to liver function, which can have a cascading effect on the body's overall health.
Exactly. And if the infection isn't controlled, it can lead to sepsis, a life-threatening condition. So prompt diagnosis and treatment are absolutely essential in cholangitis to prevent those dire consequences.
And what about the risk factors for cholangitis? Are they similar to those for cholecystitis?
There's definitely some overlap. Age, obesity, diabetes, high cholesterol all increase the risk of gallstone formation, which can obstruct the common bile duct and lead to cholangitis. But we also need to consider those malignant obstructions, such as tumors in the pancreas or bile ducts, which can also compress or invade the common bile duct and trigger this condition.
So it's a mix of those gallstone-related risk factors and those associated with tumor growth, making it a more complex picture than acute cholecystitis.
Absolutely. Now, the last piece of the epidemiology puzzle is understanding the geographical distribution of these conditions. While acute cholecystitis is found worldwide, its incidence can vary depending on factors like diet, lifestyle, and genetics. For example, populations with a higher intake of dietary fat and cholesterol tend to have a higher incidence of gallstones and consequently acute cholecystitis.
And I imagine certain regions might have a higher prevalence of those parasitic infections that can contribute to both cholecystitis and cholangitis, adding another layer of complexity to the global distribution of these conditions.
You're spot on. In areas where those parasites are endemic, we often see a higher incidence of biliary infections. It's a fascinating interplay of global patterns and local factors that shape the epidemiology of these conditions.
Absolutely. It's like a tapestry woven from a variety of threads: diet, lifestyle, genetics, and even those tiny parasites lurking in certain parts of the world. Now, speaking of those microscopic players, let's turn our attention to the most likely pathogens involved in these infections. As medical microbiologists, we need to know our adversaries to choose the right weapons to combat them.
Knowing our enemy is crucial. Let's start with the usual suspects. Given that these infections often stem from the gut, we frequently encounter gram-negative bacilli as the primary culprits. Think of those familiar inhabitants of the intestinal tract.
And E. coli is probably at the top of that list, right? It seems to pop up everywhere in the world of infections.
You're absolutely right. E. coli is one of the most common pathogens found in both acute cholecystitis and cholangitis. It's a versatile bacterium that can thrive in various environments, including the bile-rich environment of the biliary system. But it's not alone. We also need to be mindful of other gram-negative bacilli, such as Klebsiella, Enterobacter, and Pseudomonas.
So it's a diverse group of gram-negative bacteria that can cause these infections, each with its own set of virulence factors and potential resistance mechanisms.
Exactly. And we can't forget about those anaerobic bacteria, those organisms that thrive in environments without oxygen. They often lurk in the shadows, waiting for the right opportunity to cause trouble.
And those opportunities arise when abscesses form, creating those oxygen-deprived pockets within the body.
You're spot on. Anaerobes, particularly Bacteroid species, are frequently isolated from these infections, especially when there's abscess formation. They can complicate the clinical picture and require a different approach to treatment.
So those anaerobic bacteria add another layer of complexity to our antimicrobial strategies.
Absolutely. And let's not forget about Enterococcus species, another group of bacteria commonly found in intra-abdominal infections.
Enterococcus. Those could be tough to treat, especially if they've developed resistance to antibiotics. They're like those pesky weeds that keep popping up in our antibiotic garden. What about Streptococcus species? Do they play a role in these biliary infections as well?
They certainly can. Streptococcus species, particularly those belonging to the S. anginosus group, formerly known as the S. milleri group, are also frequently isolated from these infections. They often act as opportunistic pathogens, taking advantage of a weakened host or a disruption in the normal balance of the microbial community.
So we've got a good mix of gram-negatives, anaerobes, and even some gram-positive cocci. It's like a microbial melting pot in those biliary infections. But with the rise of antimicrobial resistance, I imagine we need to be extra vigilant about resistant strains, right? Those ESBL-producing and carbapenem-resistant bacteria are a major concern in healthcare settings worldwide.
You're hitting on a critical point. We're seeing increasing rates of multi-drug resistance, particularly among the enterobacterales, especially those producing extended-spectrum beta-lactamyces or ESBLs and carbapenemyces.
Those resistance mechanisms, they're a formidable foe in the battle against infections. They make our antibiotic choices more difficult and can lead to treatment failures and prolonged hospital stays.
Absolutely. It underscores the importance of using antibiotics judiciously and implementing robust antimicrobial stewardship programs to slow the spread of these resistant organisms. We need to be good stewards of these precious drugs to preserve their effectiveness for future generations.
Now, while bacteria are often the main players in these infections, we can't completely rule out other microbes. Fungi, for example, can sometimes cause opportunistic infections, particularly in patients who have received broad-spectrum antibiotics.
That's right. In patients who have recently received antibiotics, we need to consider the possibility of fungal infections, particularly with Candida albicans. Candida is a common inhabitant of the human gut, and when the normal bacterial flora is disrupted by antibiotics, it can seize the opportunity to overgrow and cause infection.
So it's a reminder that our microbial world is a delicate balance, and disrupting that balance can have unintended consequences.
Exactly. And one last but important point. In certain parts of the world, we need to be mindful of parasitic infections. We've already discussed how those roundworms and liver flukes can cause biliary obstruction, but they can also increase the risk of bacterial complications.
So it's a complex interplay of bacterial and sometimes fungal or parasitic factors that contribute to these biliary infections.
It is indeed. And understanding this interplay is crucial for guiding our diagnostic and treatment strategies. We need to consider all the potential players and tailor our approach accordingly.
Okay, so we've covered a lot of ground regarding the epidemiology and microbiology of acute cholecystitis and cholangitis. Now, before we wrap up this part of our deep dive, let's have a little fun and test your knowledge with some exam-style questions. Think of it as a mental workout to reinforce those key concepts we've discussed.
I love a good challenge. Let's put those brains to work.
All right, here's your first question. A 65-year-old woman with a history of diabetes presents with fever, right upper quadrant pain, and nausea. An abdominal ultrasound reveals a thickened gallbladder wall and gallstones. Which of the following is the most likely diagnosis? A. Acute cholecystitis. B. Acute cholangitis. C. Appendicitis. D. Pancreatitis. Take a moment to consider your answer, and we'll discuss the reasoning behind the correct choice shortly.
All right, let's revisit that first question. We're looking at a 65-year-old woman with diabetes presenting with fever, right upper quadrant pain, and nausea. The ultrasound shows a thickened gallbladder wall and those telltale gallstones.
So putting it all together, what diagnosis fits best?
The answer is A, acute cholecystitis. The combination of right upper quadrant pain, fever, and the ultrasound findings pointing to gallbladder inflammation make this the most likely culprit.
And why rule out the other options?
Well, while acute cholangitis can share some similar symptoms, it's often distinguished by the presence of jaundice, which wasn't mentioned in this case. Appendicitis typically presents with pain that starts around the belly button and migrates to the lower right abdomen. And pancreatitis, while it can cause upper abdominal pain, it's usually associated with more severe pain radiating to the back. And elevated pancreatic enzymes would be a key finding on lab tests.
Excellent. You've expertly dissected that case. Ready for the next challenge?
Absolutely. Bring it on.
All right, let's test your antibiotic expertise. A 40-year-old man with no significant medical history presents with acute cholecystitis. His blood cultures are negative, and he's scheduled for cholecystectomy in a few hours. According to the AWARE guidelines, what's the most appropriate antibiotic strategy in this scenario? A. No antibiotics are necessary since surgery is planned. B. Start with intravenous amoxicillin clavulanate and continue for 5 days after surgery. C. Start with intravenous ceftriaxone and metronidazole and stop after surgery. D. Start with oral ciprofloxacin and metronidazole and continue for 7 days. Think carefully about those AWARE recommendations and specific details of this case before choosing your answer.
This question really gets to the heart of applying those AWARE principles to real-world scenarios. There's often a temptation to jump right to antibiotics, but sometimes a more nuanced approach is warranted.
Right. We need to weigh the benefits and risks of antibiotic therapy and tailor our approach to each patient's unique situation. So in this case, we've got a patient with uncomplicated acute cholecystitis, negative blood cultures, and surgery scheduled soon. What's the best course of action?
The answer is C. Start with intravenous ceftriaxone and metronidazole and stop after surgery. The AWARE guidance specifically states that in uncomplicated cases of acute cholecystitis treated with cholecystectomy, antibiotics can be stopped once the surgery is complete, provided there is good clinical recovery.
And the rationale for choosing ceftriaxone and metronidazole over the other options?
Well, while amoxicillin clavulanate is a reasonable choice for mild cases, the AWARE guidance suggests reserving it for situations where oral therapy is preferred or if there are concerns about compliance with intravenous treatment. In this case, since the patient is heading for surgery soon, intravenous therapy with ceftriaxone and metronidazole provides good coverage against the likely pathogens and can be discontinued after the procedure.
And why rule out options A and D?
Option A, no antibiotics, is generally not recommended for acute cholecystitis, even if surgery is planned. While surgery removes the source of infection, antibiotics help control bacterial growth in the perioperative period and reduce the risk of complications.
And option D, oral ciprofloxacin and metronidazole for 7 days.
That regimen might be appropriate for mild cases where oral therapy is preferred, but it's not the most optimal choice in this scenario. Intravenous therapy is generally preferred in the perioperative setting for acute cholecystitis, and the duration of 7 days is longer than necessary for an uncomplicated case.
Excellent. You've navigated those antibiotic choices like a true AWARE champion. Ready for another case?
Absolutely. Keep them coming.
Okay, this one focuses on the microbiology of these infections. Which of the following organisms is least likely to be implicated in acute cholecystitis or cholangitis? A. Escherichia coli. B. Bacteroides fragilis. C. Streptococcus pneumonia. D. Klebsiella pneumonia. Remember those common culprits and their preferred environments before making your choice.
Microbiology is where your expertise truly shines. It's all about understanding the ecological niches of those microbes and predicting who's most likely to be causing trouble in a given location.
So we're looking for the outlier in this group, the one that doesn't quite fit with the typical microbial landscape of biliary infections.
Exactly. And the answer is C, Streptococcus pneumonia. While it's a common cause of respiratory infections like pneumonia, it's not typically found in the biliary tract.
And why are the other options more likely suspects?
Well, Escherichia coli, Bacteroides fragilis, and Klebsiella pneumonia are all frequent players in intra-abdominal infections, including those involving the biliary system. They're part of the normal gut flora, and when those anatomical barriers are breached, they can seize the opportunity to cause infection.
So it's all about location, location, location. Those gut-dwelling bacteria are much more likely to find their way into the biliary tract than a respiratory pathogen like Streptococcus pneumonia. Okay, 2 down, 3 to go. Ready for another challenge?
Absolutely. Fire away.
All right, this one tests your knowledge of pathophysiology. Which of the following is the most common mechanism underlying acute cholecystitis? A. Viral infection of the gallbladder. B. Autoimmune attack on the gallbladder wall. C. Obstruction of the cystic duct by gallstone. D. Ischemic injury to the gallbladder due to vascular compromise. Think back to those key steps in the inflammatory cascade and the most frequent triggers for this condition.
This question takes us to the root of the problem, understanding those initiating events that set the stage for acute cholecystitis. It's like tracing a river back to its source, uncovering the origins of that inflammatory flow.
So we're looking for that primary driver, that most common culprit that sets those inflammatory wheels in motion.
Exactly. And the answer is C, obstruction of the cystic duct by a gallstone. As we discussed earlier, this obstruction leads to bile backup, distension of the gallbladder, and ultimately inflammation and infection.
And why rule out the other options?
Well, while viruses can certainly cause inflammation, they're not a typical cause of acute cholecystitis. Autoimmune attacks, while they can target various organs, aren't a common mechanism for gallbladder inflammation. And ischemic injury, while it can occur in critically ill patients, is a less frequent trigger for acute cholecystitis compared to the ubiquitous gallstone.
Excellent. You've expertly diagnosed the root cause of acute cholecystitis.
On to the next challenge.
Bring it on! Okay, this one focuses on treatment, specifically those tricky cases of acute cholangitis. A 70-year-old man with a history of pancreatic cancer presents with fever, jaundice, and right upper quadrant pain. Imaging reveals a dilated common bile duct due to a tumor obstructing the distal portion of the duct. Which of the following is the most appropriate initial management strategy? A. Observation in intravenous fluids, as the obstruction is likely to resolve spontaneously. B. Immediate cholecystectomy to remove the source of infection. C. Empiric intravenous antibiotics covering gram-negative and anaerobic bacteria, followed by biliary drainage. D. High-dose corticosteroids to reduce inflammation and relieve the obstruction. Remember those key principles of managing acute cholangitis and the specific challenges posed by malignant obstructions.
This case highlights those crucial decision points in managing acute cholangitis, especially when a malignant obstruction complicates the picture. It's about understanding the urgency of the situation and choosing the most effective approach to address the underlying problem.
So we've got a patient with acute cholangitis secondary to a pancreatic tumor obstructing the common bile duct. Time is of the essence in these situations, right? We need to act decisively to relieve that obstruction and prevent those cascading complications.
Absolutely. And the answer is C, empiric intravenous antibiotics covering gram-negative and anaerobic bacteria, followed by biliary drainage. In cases of acute cholangitis, especially those caused by malignant obstructions, prompt biliary drainage is essential to relieve the blockage and decompress the biliary system.
And those antibiotics play a crucial role in controlling bacterial growth and preventing the spread of infection, right?
Exactly. We typically initiate empiric therapy with broad-spectrum antibiotics that cover both gram-negative and anaerobic bacteria, the usual suspects in these infections. The choice of specific antibiotics might vary depending on local resistance patterns and the patient's overall clinical condition.
And why rule out the other options?
Well, Option A, observation in intravenous fluids, is simply not appropriate in this case. The obstruction is unlikely to resolve spontaneously, and delaying biliary drainage can lead to worsening infection, sepsis, and potentially multi-organ failure.
So it's a case of time is tissue. We need to act swiftly to prevent those devastating consequences.
Exactly. Option B, immediate cholecystectomy, is not the primary focus in this scenario. While cholecystectomy might be necessary eventually, the immediate priority is relieving the obstruction in the common bile duct.
So it's about addressing the most pressing issue first, tackling that blockage that's causing the backup and infection.
Precisely. And option D, high-dose corticosteroids, is generally not recommended for acute cholangitis. While corticosteroids can reduce inflammation, they don't address the underlying obstruction, and they can potentially worsen the infection by suppressing the immune system.
So it's about choosing therapies that target the root cause of the problem, not just masking the symptom.
Exactly. In acute cholangitis, relieving the biliary obstruction and controlling bacterial growth are the top priorities.
Excellent. You've expertly navigated that challenging case, highlighting those crucial decision points in managing acute cholangitis. Now, ready for our final exam question?
Absolutely. Let's finish strong.
Okay, this one tests your understanding of the interplay between microbiology and antibiotic stewardship. A 55-year-old woman with acute cholecystitis is started on empiric intravenous piperacillin tazobactam. Cultures from her bile grow Klebsiella pneumonia, susceptible to ceftriaxone, cefepime, and ciprofloxacin, but resistant to ampicillin and trimethoprim sulfamethoxazole. What's the most appropriate next step in antibiotic management? A continued piperacillin tazobactam for the full course of treatment to ensure adequate coverage against potential resistant organisms. B, switch to intravenous ceftriaxone to target the specific pathogen and reduce the risk of developing resistance to piperacillin tazobactam. C, add intravenous vancomycin to cover potential gram-positive organisms that might be present. D, change to oral ciprofloxacin and metronidazole to facilitate early discharge and improve patient comfort. Remember those AWARE principles of de-escalation and tailoring therapy based on culture results?
This question highlights the dynamic nature of antibiotic therapy and the importance of adapting our approach based on new information. It's about using those microbiology results to refine our strategies and ensure we're targeting the right pathogens with the right drugs.
So we've got a patient initially started on broad spectrum, piperacillin tazobactam, a wise choice given the initial uncertainty about the causative organism. But now those culture results have revealed the culprit, Klebsiella pneumonia, and its susceptibility pattern. How do we adjust our antibiotic strategy based on this new intel?
The answer is B. Switch to intravenous ceftriaxone to target the specific pathogen and reduce the risk of developing resistance to piperacillin tazobactam. The AWARE guidance strongly advocates for de-escalating to a narrower spectrum antibiotic once the susceptibility profile of the pathogen is known.
And why is ceftriaxone the preferred choice in this case?
Well, the culture results show that the Klebsiella pneumonia isolate is susceptible to ceftriaxone, making it an effective and targeted option. Switching from the broad-spectrum piperacillin tazobactam to the narrower-spectrum ceftriaxone aligns with the principles of antimicrobial stewardship, minimizing unnecessary exposure to broad-spectrum antibiotics and reducing the risk of developing resistance.
And why rule out the other options?
Option A, continuing piperacillin tazobactam, is not the most optimal approach. While it would likely be effective, it's unnecessarily broad for this particular pathogen, and prolonged use of such a broad-spectrum antibiotic increases the risk of selecting for resistant organisms.
So it's about choosing the most targeted therapy, not necessarily the most powerful one.
Exactly. Option C, adding vancomycin, is not warranted in this case. The culture specifically grew Klebsiella pneumonia, a gram-negative bacterium. Vancomycin targets gram-positive organisms and wouldn't be effective against this particular pathogen.
So it's a reminder to always check those gram stain results and target our antibiotics accordingly.
Absolutely. And option D, changing to oral ciprofloxacin and metronidazole, is not the most appropriate choice in this scenario. While oral therapy might be considered later in the course of treatment, in the initial stages of acute cholecystitis, intravenous therapy is generally preferred to ensure adequate drug levels and penetration into the infected tissues.
So it's a staged approach, starting with intravenous therapy to knock down that infection and then potentially transitioning to oral therapy once the patient is stable and improving.
Exactly. And that concludes our exam-style question challenge. How did you fare? Did those cases test your knowledge and make you think critically about those key concepts?
I definitely learned a few things. It's amazing how quickly those details can slip away if you don't actively engage with the material. Those questions were a great way to refresh my memory and solidify my understanding of acute cholecystitis and cholangitis.
I'm glad to hear it. And remember, these are just a few examples. You can find plenty more practice questions and resources online to continue honing your clinical reasoning skills.
That's a great point. Learning is an ongoing journey. Now, before we conclude this deep dive, let's take a moment to recap those crucial takeaways, those pearls of wisdom that will guide us in our daily practice.
Absolutely. Let's synthesize those key points and leave our listeners with a clear roadmap for managing these challenging conditions.
First and foremost, both acute cholecystitis and acute cholangitis are serious conditions that demand our attention and a well-coordinated approach to diagnosis and treatment. Early recognition of those classic symptoms, that intense right upper quadrant pain, often accompanied by fever, nausea, and vomiting, is paramount.
And we can't forget about those red flags of peritonitis, severe pain, rebound tenderness, and muscular guarding. Those warrant immediate attention and often signal a more complicated and potentially life-threatening situation.
Absolutely. We need to be vigilant for those subtle clues, especially in vulnerable populations like the elderly or those with underlying health conditions who might present with less obvious symptoms.
Now, while laboratory tests and imaging studies are essential for confirming the diagnosis, clinical judgment remains our most valuable tool. We need to integrate those findings with the patient's history, physical exam, and our understanding of the pathophysiology of these conditions to make those crucial treatment decisions.
And speaking of treatment, while antibiotics play an essential role in controlling bacterial growth and preventing complications, they're not a magic bullet. Surgical intervention often takes center stage, removing the source of infection and relieving obstruction.
Cholecystectomy for acute cholecystitis and biliary drainage for acute cholangitis are the cornerstones of treatment, and prompt surgical consultation is essential in these cases.
But those antibiotics play a vital supporting role, and the AWARE guidance provides a fantastic framework for choosing the right agents based on the severity of the infection, local resistance patterns, and individual patient factors.
We discussed those first-line and second-line options for both mild and severe cases, emphasizing the importance of tailoring treatment, de-escalating to narrower spectrum antibiotics whenever possible, and adjusting dosages for our pediatric patients.
And those principles of antimicrobial stewardship should guide our every antibiotic decision, using these powerful drugs wisely, targeting specific pathogens, and minimizing unnecessary exposure to broad-spectrum antibiotics to prevent the emergence of resistance.
Absolutely. We're all stewards of these precious resources, and our choices today impact the effectiveness of these drugs for future generations.
Now, before we bid farewell to this fascinating topic, I want to leave our listeners with a final thought to ponder.
I love those thought-provoking takeaways. What do you have in mind?
Throughout this deep dive, we focused on those general principles and guidelines for managing acute cholecystitis and cholangitis, using the AWARE guidance as our trusty compass. But as we all know, medical practice is not a static entity. It's a dynamic process, constantly evolving as we gather more data and refine our understanding of these complex conditions.
That's a crucial point. The guidelines provide a solid foundation, but they're not meant to be static or applied blindly. We need to adapt them to our specific settings and patient populations, using our clinical judgment and the ever-growing body of scientific evidence to guide our decisions.
Exactly. And that's where you, as medical microbiologist, play a vital role. You have access to valuable local surveillance data that can provide insights into the specific pathogens circulating in your communities and their resistance patterns.
That's right. By analyzing this data, you can tailor those broad recommendations to your specific settings and patient populations, refining those empiric antibiotic choices, optimizing those treatment strategies, and ultimately improving patient outcomes. You're not just following the guidelines, you're shaping them, using your expertise to make a real difference in the fight against infectious diseases.
It's a powerful reminder that we're all part of a larger ecosystem, constantly learning, adapting, and striving to provide the best possible care for our patients.
It's an ongoing journey of discovery, and that's what makes this field so exciting. There's always more to learn, more challenges to conquer, and more opportunities to make a real impact.
Now, for those who are eager to delve deeper into this fascinating topic, we encourage you to explore the AWARE guidance in detail and tap into those local surveillance resources to stay ahead of the curve.
And if you have any intriguing cases or burning questions, we're always here to discuss and learn together. Collaboration is key in this ever-evolving field.
Well, that concludes our deep dive into acute cholecystitis and cholangitis. We hope you found this episode informative, engaging, and thought-provoking.
It was a pleasure exploring these conditions with you and sharing those crucial insights.
Until next time, stay curious, keep those microbes in check, and never stop learning.